Just a moment while we transfer the screen. All right, go ahead, Zaisha.
Hello and good morning. Can you hear me all right?
Yes.
Okay, wonderful. Thank you so much for having us today. We're really excited to share where we are here in Butte County with some of our evaluations overall, as well as PEI specific. We definitely recognize that we do not have all the answers. We are moving right along with everyone else. We've experienced and continue to experience growing pains around our evaluations, especially as they have changed over the course of the past 10 years so significantly, and throw in there the added complexity of integrating our electronic health record, as well as contracted providers who do not have access to that same electronic health record. So we feel the growing pains of all that just as much as anyone else. So today we just wanted to share with you some of our solutions so far and the ways that we've been able to get the data that's required to be submitted, and how we've really come full circle to figure out a way to get everybody on our team in this process. I just want to mention that today I'm joined by two other individuals here as well. Holly Drobny, who's our MHSA program manager here in Butte County, and she's also our cultural competency coordinator, as well as our public information officer. So she does wear a lot of hats up here in our rural county. However, she's an incredible MHSA program manager and someone that we work daily in tandem with on all of these efforts. And I also have our MHSA analyst, Celeste Kramer, who is full-time dedicated to these evaluations, and she actually has come to us from our crisis services, boots on the ground, after over 8 years of direct care service. And so she really brings a whole other aspect to bring our evaluations to life and really be meaningful for our direct care staff. So I'm absolutely lucky to have these individuals on our team, and we have worked together to put all this together. We are, like I said, we're still in the early development of making sure we are where we need to be with our evaluation. So as we go through this, I'm just sharing where we are, and definitely appreciate when other counties are sharing solutions that they have. We are definitely taking your lead in a lot of other areas. So we really appreciate the collaboration and support that you're all showing in sharing evaluation strategies as well. So this morning, we're going to go ahead and review the history of systems performance research and evaluations units. We're actually an entire unit, and for a small rural county, I feel like that's something really special. And I wanted to share with you how we came to be and why we exist and how we continue to exist, because for our county and our department, it has made a huge difference in where we're able to be today. I'll be sharing how we've begun creating a data-focused system, which doesn't just include the analysts in this office, our program evaluation designs, and I'll give you examples of those, our component-specific tools. I will share examples of those as well, and happy to send them to you all so that you can modify and use them in any way you would like, how we collaborate with program, and our quarterly review process. So next slide, systems performance research and evaluation. Our unit obviously did not used to exist. 10 years ago, one of our assistant directors had a vision. She really was, her finger was on the pulse of recognizing that we were moving towards becoming more data-driven and data responsible throughout the state of California. She really recognized that we needed more than one person tucked away in IT and perhaps half a person in quality management, making some pie charts and some counts of individuals so that they could make decisions on a daily basis about moving our programs forward, as well as the birth of MHSA really brought a whole new level of evaluation that was going to be required. So she actually developed that program, the manager position for this unit, Systems Performance Research and Evaluation, and the job specs which I can also send out, are very specific. They're really looking for a researcher, someone that has experience in evaluation and design, because at that time, it really was either our IT department or our quality management department. IT, we have our technical staff, and in quality management, we have clinicians. And really between the two, you really have a fit right in the middle of an analyst series that needs to be able to live between both the technical world and the clinical world. And that wasn't there yet. And so with this position, it really started the growth of a team that would be able to bridge that gap between the two. So it was also very important as we implemented Avatar, which is our electronic health record, that we needed to begin educating the department about data and how to use it, how to read it, how to interpret it, why it matters. And so they needed individuals who could become experts in that and really begin training the department. So as systems performance started, we started with that manager position and had collected a team of a couple analysts that were tucked away in different corners of the department. And that team really began to grow. We became absolutely involved with the development of the electronic health record, because if you are on the data end of anything, you recognize that if you are not on the design end and influencing how that data is going in, that you are going to get junk data on the other side, and your reports are not going to matter very much. And they will absolutely be impossible to even put together when it's time to put that information together. So we actually do most of the design work for our electronic health record. And then we work with IT, who puts it into the system, and we test it to ensure data integrity going into that front end. We work very closely with our quality management department. We are in charge of running all the data for their final rule metrics, for the PIPs projects. We run all of their data, and they present it, they review it, and we work side by side in tandem with those quality management clinicians. We're responsible for all the state data reporting, CSI, CalOMS, OSHPD, our FSP data, all of that, and all of the error corrections around that. We provide the systemizing of our system. We really go through and look at process flows and workflows to improve and implement strategies to help improve the time that it takes to do anything we do in our department, so that we have more time for clinical work and direct patient care. We do all of our surveys that go out throughout the year, and the biannual consumer perception surveys. We do all evaluations for any grant-funded programs and any other programs that require evaluations, even outside of MHSA. And then we are on the implementation team for Avatar and major implementations. In fact, our team often will be the lead on different implementations. For example, our electronic e-prescribing, because it's so data heavy, we led that implementation instead of someone from IT or quality management, but we share that as a team with those two teams. And then we provide a whole lot of training. We train on all kinds of things all year round. And so finding analysts that are able to do all of that, especially in a rural county, is quite the feat. These analysts also provide data to our leadership on a daily basis and help them to make continuous data-driven decisions. We literally have our director running in here saying, I need a number, I'm having a meeting with law enforcement, I'm having a meeting with the hospitals, and he needs that data at his fingertips. And so we scramble, we get it together, we make sure it's double validated, and we get it out there so that they can actually keep our agency moving forward and keep our citizens safe by making really good data-driven decisions, not anecdotal decisions. So really, I just described incredible staff. And what we found we're a smaller county. What I have found is that really I become a talent scout. And our team is very picky about every single analyst we put on this team. And at first, we were only a few analysts. But because the department saw the value in having these analysts, and we really brought so much value and cost savings, they began saying, okay, we'll give you another position and another position. And so each time a position opens, I put that talent scout hat on and really begin recruiting in really creative ways. We have a college here, so I send information to the college. We put it out there in every way, shape, and form possible to try to get a really good pool of individuals. And then when we're interviewing those individuals, really we're kind of looking for a triple threat. Someone who, they don't even necessarily have to come with these skills. Obviously here, I'm never gonna find that, to be completely honest. So if I waited for those people that already have these skills, I would never find them. So in fact, on our team now, currently, we have a farmer, we have someone who is a gymnastics coach, we have people who worked at our local tribal casinos, we have people from all walks of life who are now highly efficient, effective, technical analysts. So what we're looking for really, and I really encourage smaller counties to invest in their individuals and staff, look for potential. Do they have the potential to understand this stuff? Do they have the potential to really work with program collaboratively, compassionately? Are they people that can work with program, not stress them out, and then they can work with a team of highly efficient analysts? And do they have that capacity to learn high-level technical data skills? All of our analysts can build data, access databases. They're learning to write code. They can build crystal reports, but that is after a whole lot of investment in their training and in them personally and professionally. So we take really good care of them and really build them up. And so after their first year on our unit, they really become highly effective analysts who can do all of that stuff. So we're looking for people who are really good with, you know, the right side and the left side of their brain, that technical analyst, but also the people. They need to be able to get out there and train and not raise anxiety around data and the use of our electronic health records. So I really encourage that staffing is number one. Getting the right people on your bus to move this kind of a unit forward is vital. And the better your reputation is as a unit and the better your products are, the more your department's really going to want to invest, because many of us were struggling to do all of this evaluation work with not very many people. And so it's really vital you have the right people and you have enough of them to do this. So currently, we have 8 full-time analysts on our team and a supervisor and a program manager. And then I've also added interns from the college as well. And so we have interns year-round too, who hopefully potentially can grow into people who join our team eventually. If not, they potentially join the department as a better staff member out there on the clinical floor. So how do we continue to exist and grow? We have to be able to pay for ourselves, and you better believe we pay for ourselves over and over again. Not only do people like these analysts because they're so good at their job, we also, for all of our quality management activities, we can code to the UR code and draw down some funds that way. We also elected to take on the duty of writing grants for the department. And so we have one staff on our team who took one grant writing class, and she's just become a powerhouse in writing grants. And so we all work together to help her, and half of her job is writing grants at this time. And we help her write these grants. And so she has been awarded a $1 million CHAFA grant, 3 different SB 82 grants. She helps with writing some of our stuff for MHSA as well. She reviews it. But we've all just realized we need to get good at writing grants for funding. And one of the reasons our grants are successful is because we're writing it and we know the data. We are packing these grant applications full of data and facts and figures and really strong evaluations, and the funders are loving that. And so these grant applications are being more successful. And you better believe when it comes to the budget line items, we're budgeting in analyst funds for our team. And so when we have control over the application, we have control over what's going to get paid for, right? And of course, our director doesn't bat an eye. He says, absolutely. So any of our analysts that were perhaps on a 3-year or 5-year grant, you know, as we're writing new grants, we're making sure they will always have funding on our team. And now things like that come in so quickly that, you know, we're able to put together more full-time analysts to add to our team. In fact, we just added another analyst recently. And then we also leverage those interns as well, who are free but fantastic. Okay, next slide. So this slide is creating a data-focused system. However, I'm starting there, but we did not start there. And I think that this is something that actually we've come back to this over the course of this last year, realizing that this is vital. We put all this effort into designing our electronic health record, building all these reports, pulling all this data, and the data going in still wasn't really very good. And that was because, you know, we found that it was very inconsistent, incomplete, non-descriptive data. Clinical staff really didn't understand the value of what they were putting into the EHR. And so I realized we needed to front load this education. So we really needed to educate the staff about who we serve, why that data matters, what are data-driven decisions, and how do these decisions affect me, the clinical staff on the front end of all this, and our support staff as well, because they track a lot of our data. So we began a new employee orientation called NEO, and I jumped right in on this and said, I need to give 2 very important NEO presentations, and I will happily share these 2 PowerPoints with you as well, because it is vital, and we're already seeing kind of a change in culture happening. Literally, they're just 15 minutes each. They're not long, but I'm planting a seed. So the first NEO presentation I give is putting the pieces together to tell our story. And this one is really, I'm trying to kind of get to them and plant that seed of how the data is all about the people we serve and all about really helping our community to be as healthy as possible. So in that presentation, I talk about who we serve. I give very specific, intimate data about Butte County itself, about our population. I talk about our poverty rate, our unemployment rate. I talk about our Medi-Cal beneficiary rate, as well as our ACEs scores in Butte County. And unfortunately, or fortunately, I don't, you know, it's hard to say, we are well above the state average on all of these points. We have higher poverty rates, higher unemployment rates, and our ACEs scores are the highest in the state. And so while all that can sound very depressing, I make sure to let them know that, gosh, our community really needs them. So that first of all, they're in the right area of work, and that we have a lot of work to do. And in order to do that work, we need to continue to bring in our funding. We need to be able to draw down new funding, and we need to be able to tell the story of what the programs are doing out there in the field in order to make sure those programs stay alive, that they are supplemented, and that the programs that are working continue to grow, and that where we need to make adjustments, we can quickly make adjustments for our community who desperately needs us based on this data. In that specific training, I also share all the demographics of the people that we do serve. I share information about how our budget breaks down between mental health and SUD. I share all the different types of programs we offer, because just because you're going into crisis services or outpatient doesn't mean you understand all of the programs that we have and all of the data that we're collecting across all of those programs, and how many stories we really are telling that collectively shows all of the hard work that's happening and the lives that are being impacted. And I do let them know that when we have this data at our fingertips, we are writing grants for funding. When we really understand their story and what their needs are, that we are ready right away when funding becomes available to advocate on their behalf, because we have the data and we have the information. Without it, we can't even get going at all to keep their programs alive and thriving. So really just planting that seed to create buy-in, to create passion for the data and an understanding of why it's so important. So that mutual understanding. We also, I take the opportunity to really build rapport and respect for the work that they're doing, so they understand we're not just people behind the computers judging the work that they're doing or tracking, if they're doing the right amount of work and their productivity is high enough and all of those things. While those are important, really we take pride in being the voice of what's really happening out there. And we want them to understand that that's what our intentions are. This really provides them context for why there's such an emphasis on data. And if they don't know, then they can't care as much about that because they're out there really trying to save lives on a daily basis, and we understand that. So really being compassionate about that and helping them to understand. The second presentation that I do is about their outcome measures, because that is a huge piece of what we do. We get pretty good about collecting demographics and our support staff is super good at collecting data. And then the clinicians and our counselors, we really talk to them about outcome measures and why outcome measures are important. So currently we're all using the CANs, and we have the PSC we currently use the MORS, and then we have some other measures as well. And so some of the things we hear is, I just don't have time for that. It's not as valuable. So we hear all kinds of things about why outcome measures maybe aren't completed when they should be, or aren't really taken as seriously. And so I give them some insight into really why that matters and how they can use those outcome measures to really direct their clinical patient care. I use a whole lot of research on psychology and the background of our field to show that really if you're not measuring how clients are doing from their perspective and from your clinical perspective, then you really don't have any idea how they are doing. And in fact, we all rate ourselves, in our efficacy at the 80th percentile. And so if they're all doing that, it's a statistical impossibility. It can't be done. We're not all at the 80th percentile. So in order to really provide good clinical care and a full assessment, they really need to have buy-in into those outcome measures and then have the tools to really use them. We can't just say fill it out and not give them back their data. So I walk through the screens, how they fill it out, and I walk through how they can use the reports that we provide them to use that outcome measure in their clinical formulation for the client. And so they realize they have some tools at their fingertips. We also provide education for all of our MHSA providers, special outside of all of this. Upfront hands-on training. In fact, Celeste had just recently developed really powerful trainings on CSNS regulations and on PEI regulations separately. So she had our providers attend whichever one their program fell into, and she gave some different times for them to attend, and she went back to the beginning. What is MHSA? Where's the funding come from? And what are the regulations around the reporting requirements? So they would really understand. We're not just asking them for some of these things that they don't understand for no reason. We're asking them for these because this helps us keep this funding and to be able to do their full evaluation at the end of the year. And so we also have the 2 PowerPoints for that, which I'm happy to share. They're fantastic. Celeste did a great job. We give our providers so many opportunities to ask questions. We want them to ask questions. There's just no dumb questions. So we really want to make ourselves personable and help them feel comfortable asking questions. At that meeting also, she reviewed their data requirements and gave them a copy of their evaluation with their data and let them go ahead and compare their program description, outcomes, measurements, and data with the regulation so that they could potentially see any gaps in, gosh, we're doing a good job, or maybe there's better ways we can meet these requirements from that program perspective. Because again, we are not the expert on their program. They really are. They know it inside and out, and we do our best to become an expert as much as we can, but they might have insight to add that we can translate into an evaluation. and helping them just to really understand and have that buy-in so they don't feel scared and frustrated by the whole process. So one thing to mention too is that while Holly is the program manager for MHSA, the MHSA analyst is actually housed on our SPRE team. And so both Holly and I work directly with the MHSA analyst. This way, the technical aspects of the evaluation can be supervised here on the SPRE team, but Holly and Celeste work hand in hand on every single thing that they do. So Celeste, as an MHSA analyst, has double the support from both areas, and she has a whole lot of technical backup from an entire team of analysts to help fill in anywhere that she may need some assistance on that technical side. So on the next slide, I wanted to share with you, then what we do is for each program, develop that evaluation design. So as you can see, the example on the right is our Stonewall Alliance Center, and this is one of our PEI programs. For every single program, this is what the format looks like currently, and already for next year we have new ideas and additions that we want to add. However, this is where we're at this last annual update. So what we do is develop that program description. We work directly with the program to ensure that they match the program description content with their contract scope. So it's in their contract, their scope matches this program description. And then from there, the program description really informs the outcomes. They really should mirror the program description and goals and intentions. So we read through the program description with some fresh eyes, and we think, how is this program trying to impact our community and the individuals that they serve, and really try to mirror that with the outcomes that we come up with alongside with the provider. We're not doing this by ourselves. Then we look directly to the measurements. So outcomes 1, 2, and 3, we want to see measurements 1, 2, and 3. Those should line up with each other so that you can see this is how we're measuring number 1, this is how we're measuring number 2, this is how we're measuring number 3. They directly correlate with the outcomes. And in some instances, we've had to get really creative about how we measure something. And in other instances, we've had to literally decide to change it because we just can't measure what we're trying to get at. So this is just a constant tweaking every single year. We do this, we get better and stronger evaluations, and we come up with new ways to track and measure. So the last piece to this is developing tools to capture the data. We don't expect our providers to develop the tools because they're, most of them, tiny little programs who have a couple people implementing a massive program for our county, and that they don't have the capacity to do that. So we develop the tools for them, and hopefully a tool that feels comfortable to them, and we work with it until it is a tool that works for them. And so we do a lot of research on what kinds of tools will work well for them and just really get creative. And we pilot things that work and some things don't work. And we're just constantly working with the providers to make sure that we are taking all things into consideration. So I listed some considerations here that I felt like we really tried to keep on the forefront of our minds when we're looking at developing these tools. We really want to be thoughtful and compassionate and respectful of the programs that these providers are giving to our community members, and not just come in to say, we have to collect this data, collect it, give it to us. You know, that's a really difficult message when you are trying to do a whole lot with not much out there in our community. So we really look at the culture and demographic makeup of each program and consider tools that might be appropriate for that, that demographic. We look at the program characteristics. We look at which funding component they're part of, because obviously based on the component, there are different requirements. And so which tools we really need to develop. And then we're looking at trying to be really trauma informed. I went through our entire workforce this last year and gave an entire presentation on becoming a trauma-informed system, not talking about clinical initiatives. We're talking about a system from our IT to our billing, our accounting, our front desk staff, and our clinical staff, being a system that really is looking at everything we do in a trauma-informed way. And a lot of our MHSA programs are our community partners and community-based programs. So we really recognize that changes and additions can leave people to their data, can really leave people feeling like they're being graded or judged when we know their hearts are in wonderful places. This can really cause stress and anxiety and in those individuals, and then they're not going to be able to be out there doing the best work that they can do to serve our community. So we want to be thoughtful about that. We also really consider the population. Is this a population where the tools that we use could be incredibly anxiety provoking? A good example of this is our elder Hmong community, and some of the tools that we were trying to use at first were really causing stress during their program, and that is not the idea, and that's just not going to roll well. So we went back to the drawing board and really came up with new solutions and new ideas. And so we really tried to integrate that into our evaluations as well. Okay, next slide. So developing those component-specific tools. As you can see, these are our Butte County PEI programs. We have 9 service delivery programs in PEI. And each component, as you all know, have different data requirements. So I'm going to show you what we do, what tools we use for each one. Under prevention, we have our African American Family Cultural Center, our Live Spot, which is a prevention program, our Promotores program, which serves our Latino and Hmong communities, and our Zhangxia program, which serves our Hmong community. In early intervention, we have Passages, which serves our older adult population. In our outreach program component, we have NAMI. In our access and linkage to treatment, we have our Welcoming Triage and Referral program, which is a screening program. And we also have added new this year our talk line to that PEI component. And our stigma and discrimination program is Stonewall, which is our gender and sexual minority and ally community. And so as you can see, these programs are incredibly different from each other. They serve totally different populations on most counts. They have a totally different staffing on each of these programs. Some of them are volunteers, that's their entire staff. So we're asking volunteers to do all this heavy data lift, and they're like, no, thanks. So making this really easily accessible and completable is so important, as well as having good relationships with these programs. Because as soon as you spike their anxiety around this, it's just going to be shut doors, and then the data isn't really going to be any good. So we're really looking for quality data really through that partnership with these programs. They have different initiatives, and all but 2 of these are contract providers. So only 2 of these programs, we have access to data in Avatar, which for us, if the data is in Avatar, it's a whole lot easier. It's right there in our electronic health record. And we build the screens and we can get what we want so easily. It's the rest of them, 7 other programs for PEI alone, where we have to get tools that can work across our agencies and for multiple different programs. That's really where huge complexity comes in for us and causes dynamic issues. So next slide. Celeste and I wanted to show you what that PEI Access database looks like. That's the solution that we really came up with. We treat all of our data as PHI. So we don't want it living anywhere that is really breachable. So we developed a PEI Access database. This Access database is always changing, especially with these new regulations. They changed quite a bit. However, because we had started early on with this concept, it wasn't too difficult for our providers to understand this idea. But really, they designed the database to be as user-friendly as possible. So you can see the enrollment form is the first form that pops up for them. And so this enrollment form is used by our access and linkage, our early intervention, and our prevention programs. And they use this form to track individuals, their counts and demographics. So we've built in all those PEI required demographics. And again, I'm happy to share this database with all of you, a blank database, so you can use or change as you want. And Celeste was really, really smart to create as many drop-down dictionaries as possible, because when people type things in, of course, they're going to type all kinds of things, so it doesn't make it easy to pull the data. So all the drop-down menus and categories that you can create in dictionaries, the better. And so we're happy to share that with you and what we've come up with so far. But of course, like I said, we're always continuously getting better at this and developing them more formally each time we realize something's missing. So what we do is we send this database to our providers and that don't have access to our EHR. They then monthly send it into us via uShare, which is a secure data portal for transmitting consumer info and large files. So some files can't be transmitted across our email system. And so, and because this has what we consider consumer information, even though it's PEI, we want to keep that secure. So uShare is the portal that we use for transmitting that back and forth, and our providers have gotten really good at it. And so that is what we use for the enrollment form, for access and linkage, early intervention, and prevention components. Okay, next slide. The second form we use is the group forms. And those forms are used by our early intervention and our prevention programs. Perfect. And that group form then collects the staff who facilitated the group topic, the date of the groups, and the participants, and then the responder type, which is one of the regulations that we realized we needed to be collecting for the people attending the groups. Okay, next slide. The third form on there is our service log form. This service log collects the program, the staff, the service type, participant that they provided the service to, and if referrals were made. And this is for programs that provide services individually to their participants. So we use this for early intervention component, prevention component, and the outreach component when it is applicable. All right, so that's the Access database. All right, next slide. So this is beautiful. Celeste took all of those new PEI demographics and created this PDF form. Again, a form that we can send out and we can give to you all because it's so worth sharing if you don't already have a form developed. One thing we decided to do was not only use these data pieces for PEI, we're using it for all MHSA programs as well, all of our CSNS, and we'll be using it for innovations as well, so that we have the same demographics across all of our MHSA programs. And inevitably, these will be the demographics that we will provide for all of our entire agency as well. But we're trying this a little bit at a time. Sometimes it's easier and less traumatic to roll it out and work through kinks with smaller groups. So that's where we are right now, is with our PEI and our CSNS. We've rolled this out, and this is the form that we give to them to use, so they can fill it out by hand if they have programs that are out there in the field, or it's a PDF form as well. So we do adjust this form, though, to meet the needs of the individual program. If a program comes back to us and says, gosh, we have an older adult population, we need larger font. If they say we have youth who wouldn't necessarily understand this language, then we will adjust the language. We will take out the questions that are not relevant to youth, like highest level of education completed. If this is only a high school program, we know the level of the youth in that program, or veteran status. Clearly, you know, a ninth grader isn't going to be checking that box. So we will take it off the form altogether, just to make the form more usable for their program, but recognize that we still need programs to enter the data at the time of data entry. So that's one nice thing, is that we have a universal form, but we will modify it to the program needs. However, we did have some kickback, honestly, from programs saying, these aren't relevant to us. We don't believe we should have to answer these questions or ask our participants these questions. And we just said, we need to, so let's work together to figure out a way that this is comfortable for you. And in all circumstances, we've been able to do that. We have not had a situation where we've had holdouts or anyone that just absolutely said they wouldn't do it, because we really spend the time to develop the relationships and then to make sure that they understand the importance of this data, and that we're not just making it up, that this is part of the requirement to continue our funding and to grow our funding, and we really have to come to a place where we can get this information. So sometimes this is really difficult, and we go through months of working with programs to wade through how we can literally implement this, because it is difficult. It is not easy for all programs. Every now and then you get a program that's like, oh, thank goodness, an easy one. But most of the time, it's difficult to really bend all of this to their program and what they're doing. Next slide shows a couple of our other tools that have been developed specifically for specific programs. So here's a perception survey for our Stonewall program. They go out there and they give presentations to our community and to large groups of people. And so for their stigma and discrimination reduction requirements, we developed a pre and post survey. So this survey is given before the presentation and then again after the presentation. What we did was we researched existing tools, and while we didn't necessarily find one specific for this population, we found one that we could change the wording up on and use for this population. And we then vetted it with the provider to make sure that it was sensitive to their program, that it was culturally competent to their program, and that they felt comfortable administering this. Because if they don't feel comfortable, we need to go back to the drawing board. If they feel like this will be a good representation of the work that they're doing or not, we take that into consideration as well. And so this has been the survey that we've used for quite some time, and have been getting really strong results from this survey. This is then the second document on there, and I'll show you some results from that survey at the end of this presentation. The other document on here is the contact log form for NAMI. They do a whole lot of meetings and trainings, and this is part of the outreach for increasing recognition of early signs. And so we developed this PDF form they can print or use electronically. So they indicate the staff member, they indicate participant names, how long the service lasted, and if referrals were made and where they were referred to. Tracking referrals, of course, is very difficult, and something that we can only track connected referrals if they are connected then to our system of care. However, we can at least track all referrals made. And so on the back end, we are able to track if they did get connected to our system of care. But this is just an example of the form they can use. And NAMI also puts that data into the Access database and sends it in. So all of the things that go into the Access database, we also create forms for them to use as necessary to make it as easy and streamlined for them. Okay, next slide. All right, so program collaboration. This is huge. This is really what kind of brings things full circle for us. This is after we've developed our evaluation collaboratively with the program, we've developed all of their tools, we've trained them on the CS&S PEI components and how to use their component-specific tools. We then, after all of that, meet with them quarterly. We meet every quarter with all of our MHSA providers, and that meeting consists of the MHSA program manager, the MHSA analyst, program supervisors from the programs. Usually it's just the supervisors. Sometimes they bring staff in as well, but a lot of times it's just the supervisors. For a couple times a year, our contracts department comes in to talk about units of service and things like that in tandem with their contract. And then sometimes our assistant directors will come in to those contract meetings as well to address any issues or concerns or things like that that have come up with different programs. So what's great is there's a lot of value packed into that quarterly meeting. So our providers know they really want to make time for that meeting. They want to be there at the table because we're going to provide a lot. These quarterly meetings used to be about 5 minutes long, just how they're doing on their units of service, and that was really it. And so now these are fruitful meetings with our providers to talk about all kinds of things. What we talk about, we go through their program description, make sure that still matches up. We have had the experience that programs just kind of morph and change depending on, things that are happening in our community and with their population. And so we really want to make sure that our program description is still strong, that it still makes sense, and that we still have a really good, strong understanding of their program and their initiatives. We also review the data that's collected. I'll show you an example of what that data looks like in just a little bit, but we show them what their current data is looking like. So it's not data from 2 years ago. This is data for current initiatives and current regulations. So we really hustle. Celeste has to put together over 30 different, dashboards for these programs to look at. So we've really looked at, writing crystal reports is huge, and so that you have it more automated, so that when you're updating data, it doesn't take you a long time to rebuild entire reports. So we're looking for efficiency so we can get data back in the hands of our providers as soon as possible so they can make adjustments, and so that we can know if we have any data integrity issues, if we're looking at something the wrong way. We need it readily available as quickly as possible for review. And to do this with just one analyst definitely means that we have to automate as much as possible. So as many of these reports are push button reports, as much of this is built in to the system as possible so that these can be quickly compiled. At those meetings, we analyze the trends. How are we looking? Are we looking like we're going to meet those goals and the outcomes that we're looking for? Are we seeing a dip anywhere? What trends are we seeing? And are those trends a result of program change, a result of data entry issues? What are the issues? And then we address any issues or concerns that anyone on the team is having. And if they suggest they may be having issues with data collection or filling out the forms or the tools that they're using, then we regroup and we provide opportunity for us to provide that technical assistance and training as needed. And really 99% of the time we're out there with them in our large rural county, wherever they're at, sitting with them, working on it. And so we really just try to partner with them as closely as possible. We have found that when they're seeing their data throughout the year, that it really makes a big difference, because not only do they start to feel really competent around understanding their data, they get the value of it and they know they're going to get it back. There's no surprises by the end of the year when we're compiling their full year report. They're not surprised at what those results look like, which, before, when we did not have this data available throughout the year, we would get to the annual report and they would be like, wait, no, something's wrong, and we now can't go back and fix it. Or they don't like their evaluation and it's just too late. So with this quarterly review process, they're getting opportunity to provide feedback, and we're getting opportunity to ask questions, because with that many programs, we can certainly miss things along the way. And we just work really closely with the MHSA program manager. She keeps us in the loop on any changes that are happening that could affect evaluations or the component that programs fall into. If a program's going to change from CS&S to PEI or the other way around, we have to completely change the evaluation potentially. And that is going to be a huge amount of effort. And so she keeps us absolutely in the loop on everything that's going on. We really want them feeling successful around data, and we realize most of them did not go to school to be data analysts. And so it's really important that we just help them feel safe, secure, and successful. Now, a huge piece to all of this that we all really wanted to make sure that we mentioned, because we feel like this has really lent a lot to the success of our data collection and given us a little bit of muscle around it, is that the scope of work in the contract includes data submission expectation and timelines. Every single contract year, Celeste reviews the contracts, and she makes sure that their individual evaluations are placed into the contract. No surprises. They know what requirements they are going to be submitting data on. Then monthly, the MHSA manager is notified by our analyst of which programs have submitted their data. And if they don't submit their data, it's due by the 15th of the following month. If they don't submit their data on time, and we of course are communicating with them if there's issues, we're not trying to stress them out about it, but we just want to make sure that they're communicating with us. If the data is not received, the MHSA program manager will not approve the claim until the data is received. And so it's really good. We just kind of say, well, we just can't till we have the data. So it really gives them incentive to make the data a priority and to get that into us. Of course, we do this in the most kind way as possible, and we work with them, and we're on their team. Hey, we want to help you get this in. Do you need us to come sit with you? Do you need help? What do you need? And we certainly will partner with them, whatever they need. And because we have interns here, if it's a matter of data entry or whatever, they can send stuff over. We can, they can courier it right over, and we can have interns help enter. We don't do that on a normal basis. But if something comes up, they're down staffing or something has happened, we really want to lend a hand to make sure that they get their data in and that they get their claims processed so they can keep their programs running. And so we just really let them know we're on their team and working together to do that. And so this happens every quarter. And so it is a quick turnaround, but a really important part of the process. Okay, so next slide shows in the quarterly meetings, we are providing them with their data. So here's kind of a glimpse of what that data looks like. So this is for the Stonewall Alliance program that I shared the program evaluation with you earlier. And we have their demographics here. So this shows the new PEI demographics and how we lay that out for them and try to make that as user-friendly and dashboard-like as possible and dynamic for them. And they're constantly reviewing this at each quarter. And we just make sure that the numbers are looking correct and lining up with numbers from the previous years. In fact, in our 3-year plan, we went ahead and compared 3 years. So in the annual update, we're looking at, for most programs, just that year. But in the 3-year plan, we're looking across a minimum of 3 years of data in a lot of circumstances so that we can see how the counts are changing and outcomes are changing. So that is the just demographics, basic demographics. And the next, and we're happy to share, this is all in our annual update that's posted on our website. And you're more than welcome to go look at all of our programs and what we've done so far. So the next slide is more of the data. This shows those disability status and type, as well as how currently we are reporting our strategies. So for the strategies, and we're definitely interested in how other people are reporting their strategies, but this is how we are currently reporting our strategies. We just partnered with our programs to answer those strategy questions to really understand how they are meeting them. And so those are the strategies. And then the next page shows that pre and post survey that we provided for this program. So next slide. Perfect. So we review these results with them as well. So the question, knowledge of resources available to our LGBTQ+ community, from strongly disagree to strongly agree, or they just didn't want to answer, that's okay. So these are those those outreach, those public presentations that Stonewall's doing. I got to take this in my foster parent course that I had to take a couple years ago, and it was really interesting to do the pre and post survey as a participant. And so able to beforehand, you can see easily that people just did not feel equipped with this information and did not feel confident in their ability to understand the community and support the community. And the post survey results are showing that people are leaving there after that training feeling a lot more confident in how to support that community in our Butte County area. And so this is a really great way to show that those results for that program. So that is our quarterly review. It really just takes everything full circle. So from our unit developing to our presentations when staff first come on board, to the development of the evaluation, to the development of the tools that we use, to then meeting with them quarterly and really developing relationships throughout this entire process is incredibly vital, and increasing our analyst skills while they're trying to do all of this work. You wouldn't believe, you know, the incredible team that we've been able to develop here, and they're just constantly learning, constantly growing, and the department really has invested a lot of energy into this unit because they see the value that this unit brings. And the incredible work that's coming from this unit. So this is one analyst doing all of this work, but she has an entire team supporting her and helping her facilitate all of these data needs. And then she just works incredibly close with our MHSA program manager. So those are the things that have helped us to be successful. That's where we are right now. And of course, even going through this annual update this year, we already have big ideas for next year. We're really excited to get feedback from the OAC on our plans and examples from other counties about what they're doing. But for us, being a smaller rural county, we really just wanted to show how we've developed some of the tools that seem to be working so far for our smaller providers in a more rural county. So the last slide has my contact information. I'm more than happy to have conversations or to share with you anything else about what we do even outside of MHSA. So please don't hesitate to reach out and contact me. And after this, I will be providing all of our materials to the OAC so that they can send it out to you. And we'll be reviewing questions too. And if there's questions that we can answer that came up in the chat, then we'll be answering those in just a little bit. Thank you.
Thank you so much,